Welcome to our second interview for the Healthcare for Language Access series, which we're doing at Ad Astra. I couldn't be happier to be here with Alexander Chiu. I won't even start to list all of his titles and his accomplishments and how he fits into access for people with limited English proficiency in part, but broader, how technology is driving the change for greater access for anyone requiring healthcare. So Alex, please go ahead, introduce yourself. Tell us about your background if you could to start, how you came into air visits, and just where you see the interesting things to comment on telehealth.
Thanks, Jeff. Appreciate the introduction. So a little bit of background about myself. So I'm an emergency physician, still practice, but I'm also the CEO of Air Visits, and really started this company with a handful of other docs to really make healthcare operations and the vision of what healthcare should be more in a line of what is going to be able to help the patients reach the next level of care, really to optimize their care better than what it is today. And so when we came around to start Air Visits, the main thing that we do is to identify the top 10 causes of death and really try to address those top 10 causes. We do that through what we call the hospital that you take with you. Air Visits is just one of many different divisions that we have, and it really starts off with more acute patients and the moderate and low risk patients. How do you really create something that is replacing what they would be able to get within a hospital, and then also observation time? In emergency medicine, this is something that's very important to us because we make a lot of decisions every day on who's going to stay in the hospital and then who's going to be discharged home. So we went about and we built a lot of the wearable monitors and control center that is able to manage patients remotely, not only with monitoring their cardiac signals, but also being able to do video conferencing and a lot more visits with patients that might not be able to make it to the hospital. And what we're finding is that the majority of a lot of the care that we offer in the healthcare system in general does not need to be in person. The walls are not medically necessary for treatment. So therefore, that we offer that is of medical necessity is a lot of the basic core needs of healthcare: diagnosis, prescription, testing. Those types of things don't need hospital walls to be able to deliver, and you can really achieve a lot of the same outcomes. And so now this is what we offer at Air Visit, to be able to not only treat patients, but also give the tools to other doctors that might be thinking the same way.
Excellent. The thing that I find extremely fascinating is we've realized, a lot of us, so many things are not necessary to do in person. Just kind of start asking some questions here in terms of your perception of today's new landscape and what that's looked like for you. If you could tell us, thinking broadly now for a moment, public access to telehealth easier today than it used to be?
If you're speaking about the public access to telehealth, so can a general person reach a physician or a provider via however you call it, telehealth, telemedicine, video visits, monitoring, whatever it is it easier during the COVID pandemic than it is normally during a non-pandemic time? I would have to say that it is mixed. At times, it can be a lot easier because during the COVID pandemic, we're seeing a lot more physicians and providers offer telehealth, but we're also seeing a lot more physicians and providers, a lot of doctors' offices that are closing, that are offering limited hours. So you might not be able to find your doctor very easily during the pandemic because it does require their adoption to perhaps a new type of care if they've never done telehealth visits but before. There have been a lot of sanctions that have been lifted to allow more physicians to do telehealth. If you wanted to find another doctor that's out that would be able to refill prescriptions or do some basic care, then there are a lot more plentiful physicians that are doing it, just because the sheer volume of physicians that have adopted telehealth out of necessity during the pandemic because their in-person offices have closed. And this is the only way that they can keep in business, is to be able to offer telehealth visits. They don't know your history. They might not know all of your diagnoses and what medications you respond to best. So staying with the original physician that manages a lot of your care or the care team is still the best way to go, and really seeking whether it's in-person care or telehealth care through them, just because their continuity of care will offer a higher level of care than just finding a doctor online that can treat you. So Jeff, that answer really is mixed, that the high continuity of care level is reduced during the pandemic. The access for expansive care, it'd be any doctor, has increased dramatically. And this is what we're seeing in the industry right now.
Interestingly, what you said there, it would be your recommendation to, as a doctor, to continue to seek care with the team that you have been working with, are comfortable with, have the information with.
I would say most physicians are less prepared for that. And if they're not prepared, it is up to them to be able to find the right resources to take care of the technology and the compliance and the privacy and also the contingency purposes. One of the largest problems with primary care physicians now, and also with specialty physicians now, is this top two is they don't know how to chart and bill for this. This is a new type of care outside of their business practice. And then the second thing is they're less prepared for emergencies. So in a standard physician practice or in a hospital, if you have an emergency, you can either call code red, code blue, whatever it is within the hospital, and there's a code team ready. And in a regular physician practice, you can just call 911 and an ambulance or a paramedic will be able to show up to take care of the patient. However, over telehealth, if you're having an emergency and you're speaking to your physician might not be able to help you unless they have the right type of infrastructure in place. And this is one of the things that is overlooked when a lot of physicians build an infrastructure.
One of the things that is certainly a common area for us to discuss here, for both emergency and non-emergency situations, sometimes you will have patients who don't speak English or are deaf or hard of hearing. How do we make sure that these patients who we also love just as much are able to be cared for the same way?
Yeah, so what we're seeing, Jeff, this goes back to one of the initial questions about access and then also splitting the access up into physicians that you know and have a relationship with and have been treated, and then physicians that you don't know. Well, with the physicians that you know, ideally a lot of those problems in terms of language and other types of barriers to hearing would already have been solved. Now you're introducing another problem of video conferencing. So if you had a special device, perhaps that was in the office, and now you don't have that device outside for video conferencing, for hard of hearing, that could still be a problem that your physician really should address. However, if it's a language problem and that physician already speaks the same language or has staff that speaks the same language as you do as a patient, a lot of those would already be solved. I'd say for new practices, ones that have national presence for telehealth services, where you might have never seen that doctor before, I'd say that that's definitely a problem of if you have a language barrier. Perhaps your English skills are good, but your medical English skills perhaps are not quite as good, and you'd rather have that interpreted into Spanish, French, or some of your own home language where you can better comprehend what is being said by that physician. That is potentially a huge problem because things get dropped. Patients don't complete tests because they don't understand it. Patients' motivation to complete testing and treatment do not happen because they don't understand it. So I'd say that is much larger of an issue than people might think.
Okay. And to go just a little bit further on that point, when you do have a language barrier or any sort of access barrier, let's talk about language barriers. Do you think that the solution is to have, if you have the right provider in place to handle that, with the right processes, will that work? Or is the solution more to staff people with native language proficiency? What would you say is the avenue to explore for that? At Astra, trying to provide any solutions that we can, right, in order to bridge this communication gap when it arises. I'm curious about how we can handle that. There are several ways. And if we really think out of the box, we can kind of get down to what all those options are.
I would say that the question you pose in terms of should you staff a lot of people within your office that can speak different languages, right, on your team versus also supplementing or completely having another translation service like at Astra or others. And I would say in my experience, you need both. And we have a lot of patients that speak English. And then our second language that is most predominant in our patient population is Spanish. And then after that, it's English, and then there's a couple of other dialects. Outside of Chinese, and also I guess there was French dialects too.
Tell us where you're located, by the way.
And we're located in New Jersey, and so there's a plethora of different types of languages that are represented not only in New Jersey but also in New York, California, and a lot of other places where we see patients. We have Spanish-speaking staff. We also have staff that can translate outside as well for French and some of the other languages. I would say that there is a strong need for blend, but also having that contingency of what happens when there is a patient on the line that needs medical care that is possibly short of breath. During the COVID pandemic, there's a lot of patients that are short of breath, and this is a sign that their COVID is getting worse. And they're introducing us to a sibling, grandfather, grandmother that has an emergency, that is short of breath, or they themselves have that problem, and they don't speak English, and they don't speak Spanish, and I have no one in my office that can communicate with them. It is imperative to be able to have a solution during those times. I would say for emergencies alone is like we go back to the infrastructure. Number one thing is everyone misses out on is proper billing. They don't know how to do it. Second thing is Response to emergencies. They don't have a plan in place to respond to emergencies. So just like that, you have a grandparent that is short of breath now. Most of the entire family speaks another language. You can recognize that it's an emergency immediately. You can't speak to that patient, and you really want to activate 911 or something that is in their location. And they're worth it to be able to have a solution in place to be able to respond to that emergency, communicate with that patient, and say, this is what you need to do right now, because you're remote from that patient. And if their
Right.
cell phone dies and they hang up, you have nothing. You have no way of being able to get in contact with that patient. You don't know where they are, and you can't activate services to be able to respond to them either.
Not only do you not want that blood on your hands because it will weigh down on you psychologically, but you also legally need to make sure that you're prepared for that as well, I imagine.
I'm not a lawyer. I'm a doctor. I treat patients. So I don't know the legal precedents behind it now. So I really have to recommend speaking to a great healthcare attorney about the liabilities, about the platforms that you choose, and really the infrastructure that you put together. I can say that the liability for telehealth is on the lower side compared to some of the other specialties.
Mm-hmm. Very interesting. Well, look, I take from that people like you and people like me who genuinely want to make sure that we are reaching as many patients as possible and centralizing our thinking on the patient. Want to make sure that they're able to have access to what they need in situations like emergencies. That's absolutely something to be prepared for. Now, shifting gears just slightly, I have a really interesting question from Barbara, staff member, an Ad Astra staff member. You can see a picture of her right here. She's actually all the way down in Argentina. Barbara in Argentina, project manager at Astra, says, I was interested in knowing, how do you train doctors to deal with emotions of patients through a screen? And I guess beyond doctors, how do you train anyone to deal with emotional situations through a screen? She says, I guess it could be difficult to manage people's anxiety. What's effective?
The training of physicians and the training of staff, we train on all levels, not only the emotional side, but also the clinical side, and being able to make diagnoses through the video and what to look out for. It's different than a tactile exam. And you're absolutely right. Having a non-in-person visit changes the dynamic of the relationship and the conversation that you have with that patient. However, we weren't the ones to invent it. Suicide lines have been doing this over the phone for a very long time now. There have been a lot of different types of interactions that we have over video where the emotional exchange does happen. And now that we're within the COVID period, it has exacerbated even more. People are having parties and meetings over Zoom. So I'd say it has been slightly a challenge to be able to reach patients in a different way on an emotional and rapport standpoint for the last 10 years of telemedicine. But I'd say for the last 4 months during this pandemic, it has been easier and easier because the adoption from just normal, regular interaction has already been there. And it's been really increased by the isolation that people have already been experiencing. And this is just one step up from that and being able to talk to a doctor over the same video platform as you would on your iPhone doing FaceTime.
Okay. I understand your history and how much you know about where we are today, right? If you're going to look into your crystal ball, you see how, you were ahead of things to be able to make the changes a few years ago. Now you see that everyone is having to do, not just healthcare, but their whole lives remotely. Where will we be and what more will we have in, let's say, 1 year's time, 5 years' time with access to healthcare? Or are we going to go in the other direction and this isn't going to work? It's just a fun experiment. How do you take that?
I think what has happened is that the increase has always been there. Telehealth has been increasing every year over year for the last 10 years. And this pandemic has now bolstered that, probably pushed us another 5 years in just a few months. So we've seen hospitals that have started off only doing 50 encounters a month go to 1,700 and 2,000 encounters a month. One of the other chief medical officers of a 11 hospital system that I was talking to said that they will never go back to fully in-person visits.